September, got it. Everybody got it, right? September is Pediatric Sepsis Awareness Month. And we have two really interesting cases for you tonight. But two things. Do we want to do our quickie survey? So Chelsea is hoping to gather data for this fantastic group of people that get together to talk about pediatric calls. So every month we're going to do a little data collection that's topic specific. So I'm going to let Chelsea do her poll, which we're so grateful that you've learned how to do this, Chelsea.
Yeah, thanks. Me too. I'm not super familiar with Zoom, but I'm getting more familiar. We use Teams at work. So for those of you who've been on the last couple of EMS for Children case reviews, like Kate said, we're trying to do some pre and post case review survey polls just to gauge where people are at in terms of the content that we're presenting. And it's all anonymous. And so there's just one question. It's just a Likert scale of your comfort level in recognizing the clinical signs of sepsis. And we'll ask the same exact question at the end of the presentation. And I will launch that right now. Thank you, everyone. And if I seem a little distracted, I'm monitoring the.
And do we want to assume in children, or what are your? I don't know.
You know, probably, since it's an EMS for Children case review, I didn't specify that, but probably.
It is, yeah. It's for pediatric sepsis. It's definitely for pediatric sepsis. Well, that's why we're here, right?
Yeah. Yeah. Thank you for clarifying that. All right, I'll give it another couple of seconds. Still admitting folks from the waiting room, and I will close out the poll. Thank you, everyone.
Thanks for doing that. Well, excellent. Well, so it's Pediatric Sepsis Awareness Month, and we have a different format for you tonight, something new and exciting. Joining us tonight is a Vermont EMS provider, Jenna Lindeman. Jenna is an advanced EMT who runs as a crew chief for Jen's Area Rescue Squad. Jenna is the training officer, right, Jenna? Yes. And then she's also one of the PECs for District 3 that really focuses on trying to get things like PEP and pediatric specific training. And Jenna's family actually had a very interesting experience with pediatric sepsis that they are going to share with us tonight. So Jenna, do you want me to run the slides, or do you want to share your screen?
I'm going to see if it'll share first, because it might be a little easier. If not, I'll pick you up on that.
No, that's perfect. That's perfect. So Jenna's going to take it away. She has permission to share this with all of her family members, and I think it's going to be really interesting. And then we'll follow up with a Vermont EMS call after Jenna's finished. So Jenna, take it away. And if you need help, we can make you a co-host. I think Chelsea is on it.
Yes. All right, 1 second, see if it's going to let me. How's everybody doing tonight?
We're good.
All right. Let's see if it will let me share this.
Oh, you've got a fan club on the chat already, Jenna.
All right. Let's see.
While Jenna's making that happen, if there are multiples of you at a location, could you just put up in the chat how many there are? And Nancy's iPhone, I'm wondering if it's Nancy's iPhone 3 or if you have 3 iPhones on, or 3 Nancy's. Katie, there's 2 of you. All right.
Okay, I might have to have you share it. My computer decided to change all its settings on me.
Oh, Richford's got 3. Okay. We got Patty and Patrick date night. All right, I will share.
Actually, did that just do it?
It's beautiful.
Okay. Yep.
Dr.
Moving too
Page,
fast
do
for
you
me.
want to monitor the chat?
All right. How does that look?
It's beautiful.
Okay. All right. So is everybody good to start?
Yes.
All right. So hi, everybody. As Kate mentioned, my name's Jenna Lindeman. I'm an AEMT. I run at Virgins and Shelburne, and I'm the PEC for VARS and also the co-PEC for District 3. Tonight, we are bringing you a case that's very dear and personal to our hearts that our family went through last April. The parents of this child, that's actually my brother and sister-in-law, are actually also listening into this, so they're able to provide some feedback or some details that I might have missed. But keep in mind too, all the photos in this are actual photos we took during the event. This case takes place in Maryland, in Great Mills, Maryland, where it starts. It's about 90 minutes south of Washington, D.C. And so it's a little out of our area. To give a little perspective where their area is, their local hospital is closer to like a Copley or a Porter. And then it sounds like more serious cases get sent to the specialized hospitals in Washington, D.C. for higher levels of care. So our story tonight starts off with a 4-year-old male. His name is Aiden. He is on the autism spectrum. Prior to this, so this starts on April 4th, he had just started speaking. His medical history is only including some ear infections, does not take any daily medications. He's got several allergies, but otherwise he is a fairly healthy, normal, happy kid that loves doing laps around his house. So our story starts on Tuesday, April 4th, where Aiden had spiked a fever. His parents gave him some Motrin, but noticed he was still happy and he was able to go to bed that night just fine. On Wednesday, April 5th, he started vomiting. There was a low-grade fever present, and they noted that he was unable to keep fluids down and food. So they did what normal parents do and take their kid to the pediatrician, where he was checked for strep, flu, COVID. They did a full respiratory panel. But at this point, as they were waiting on tests, they had deemed that was more of a viral infection. Sent him home and said, let's monitor, let's take care of him and see how he does. From there, unfortunately, that's where things start to go downhill. So Thursday, April 6th, the night before, Aiden hadn't really been able to get much sleep. His dad was up with him most of the night. He was vomiting during the night. They found he was able to get a few hours of sleep during the night, and he was able to drink some coconut water around 9 a.m. that he was able to keep down. He did show some signs of improvement. However, after 10 a.m., they noted he started to become more tired. They did note some minor shortness of breath, but he took a nap. You know, as a kid who's not feeling well, decides to go and see if sleeping makes you feel a little bit better. However, around 1500, they noticed he was limp, lethargic. He had a loss of control of his bowel. And they noted his feet were purple, which is not normal for a 4-year-old kid. So these are actual photos that were taken on that Thursday. And as you can see the progression of sick, you can kind of notice like around 11, like he doesn't look like he's feeling very well, nothing super notable. But then around the 1500, you can see his feet and the color of his feet. And that is not a normal color for a child's feet. So from there, EMS was activated. Their local rescue squad is named Valley Lee 2nd District Volunteer and Rescue. The photo on the corner was actually taken at the hospital that day. But what EMS providers found was a pale and mottled 4-year-old boy. He was being supported by his family. Family advised of the history, and they found his vitals to be, as you see on the screen. His BP was 53/33, heart rate was 120, and his blood sugar was 34. He was found to be hypotensive. They were able to get an IV in his right hand, which I think is pretty impressive. And he was transported to their closest facility. At this point, kind of hearing what you guys hear and what you saw, would you consider this kid sick or not sick?
Very sick.
Agreed.
Holy crap, sick.
Yep. Holy crap sick is definitely, especially with the people, the purple feet. What the EMS crew did was they gave him 500 milliliters of lactated ringers. They gave him oral glucose to start, but when they found his blood sugar was not improving, he was started on a bag of D10. And they had about a 30-minute transport, I believe it was. So this EKG, we actually found some leads we found from his chart. Does anybody notice anything significant on the EKG? We didn't really notice anything significant. It looked fairly regular to us, which we were hoping was a good sign. So from here, he arrived at his local hospital. He arrived around 16:04. They found his blood sugar was still 30. His heart rate was in the 120s. His blood pressure had improved to 60/40. His SpO2 was 90% en room air. Respirations were elevated at 32. Only had a low-grade fever at about 99. But it was noted that his cap refill was greater than 6 seconds. And they did note clear lung sounds at this point, but they were shallow. The labs I found notable that I thought would be good to share for this presentation where he had a pH of 7.13 and a lactate of 7. Can anybody remember what a normal pH range is?
7.35 to 7.45.
Yep. So he was pretty low on that pH scale. Did anybody kind of remember what a normal lactate level is?
Not 7.
Definitely not 7. I think what our labs usually record is below 2, and this lab used the same range. On repeat vitals, they found his heart rate to be in the 150s. Blood pressure had improved slightly. There were some interventions in that, and respirations were still elevated. His MAP noted to be in the low 40s at points. The photos you guys see on the side was at him at his local hospital. Definitely sick. You can see his skin's very gray. His eyes look very tired. So this was an EKG that the hospital did. Anybody notice anything that's remarkable about it? So they marked it as a normal sinus rhythm, which we thought was at least something positive at this. So interventions for what the local hospital did is they noted persistent hypoglycemia. So they started a second bag of D10. At 16:35, after when they rechecked his blood sugar, they noticed it to be 602. So it had gone up just a little bit. They found that peripheral access on him became increasingly harder. The EMS IV had infiltrated. There was a tibial IO started on his left side, and the doctor decided to get an IJ, which I thought actually was pretty interesting to read in his paperwork. They gave him lidocaine through the IO for pain management because he was still awake at this point. And they started a epidrip, and they also later added a neuroepidrip to his medications as well. It was noted that he had been given Narcan because at one point his breathing got very slow and shallow, and they noted pinpoint pupils, but it had no effect, and there was no risk of opioids or any opioid overdose regarding this. So after interventions, his heart rate came down a little, came down to about 120. His BP improved to 73 systolic. They put him on a little bit of oxygen at 100%, 4 liters per nasal cannula. At this point, the doctors were looking at septic shock. Considering all the vitals they had seen, the continued vomiting, the diarrhea, they were thinking there was a source of infection and considering that. There was a concern for meningitis at this point. They were looking at some blood in his CSF fluid, and they did take blood cultures. I did note in his paperwork, though, they actually were not able to get a firm diagnosis on the meningitis because the culture had clotted. Additional information is that they upped his epi drip. to, so you guys can see the new dosage, they almost doubled it. They started him on antibiotics. They had intubation on standby, but deemed that because his mental status had improved with their interventions, it was not needed at that point. During a lot of this too, the doctor was in contact with Children's National to transport him to a higher level of care, into a more specialized level of care in the form of the pediatrics department. Obviously, you guys can see that he was deemed very sick and needed to go to somewhere that could kind of care to the pediatrics. Helicopter was considered, but due to weather, was not able to be obtained. St. Mary's is about a 90-minute ground transport to Washington, D.C., and they left St. Mary's around 2033. During that transport, they actually noted his left tibial IO blue, and they had to establish a right-sided one to continue to have access for it. If anyone's actually ever been to Children's National in Washington, D.C., it's a beautiful hospital on the inside. Lots of colors. You could see why it's very children friendly there. But Aiden arrived around 2200. He was admitted to the PICU. At this point, they had noted positive growth for COVID-19 infection, and he also tested positive for rhinovirus. These were actually noted in his St. Mary's paperwork that were then later passed on to the ground transport. Children's National advised us that they would be treating him for hypovolemic shock at this point. They said they had seen this, they would treat it, that he would be doing well. They made the decision, though, to allow his body to rest and to do a medically induced coma and to intubate him, let his body, try to heal itself. And they did do an echo at this point and noted that he had myocarditis, which was a new finding. At this point, his vitals kind of had stayed the same from St. Mary's. Heart rate was in the 150s, blood sugar had come down, respiration had increased, sadly. His blood pressure ranged to 65 to 78, but with the medications they had, it was noted to have titrated up to about 121. But his pH stayed at 7.13, which is still very low. So unfortunately, this is where things take a turn. Around midnight, the doctor was called to the room because they noted a desaturation in his SpO2 and his end tidal dropping below 15. They did the normal quick check of any of the ventilator symptoms, but quickly noted there were no palpable pulses, and CPR was initiated. They moved to bagging. He was noted to be in a PEA, and they did get RAS at 22 minutes after midnight. Multiple doses of epi were given, but for the next 3 hours, they would be working Aiden in and out. He would get RAS, they would go back into arrest. He would get RAS, they would go back into arrest. He was found to be in PEA. He was found to be in junctional ectopic tachycardia. They had given him multiple doses of cardiac epi, calcium. I also noted they had given him amiodarone, adenosine, and bicarb. His end tidal stayed between 21 to 37, which was a positive sign. And during this point, Children's National actually has the capability to do ECMO. They made the decision that in order for Aiden to survive, he would need to be placed on ECMO. He was placed on ECMO at 2:48. There was a slight moment of asystole, and then he was found to be in sinus. So this is actually a picture of Aiden in the ICU that night. So you can see there's a lot of wires, there's a lot of tubes. His face was very swollen from a lot of the medications. In the days following, there was a concern for brain activity, obviously with the downtime. He was placed on an EEG, and after 2 to 3 days, they actually noted that he had good brain activity. They did find that he had a small stroke on the left side of his brain. They did and I'm gonna pronounce this wrong, an atrial septostop. I can't say that word, procedure, but it was successful. Pretty much what they described to us is they put a hole between the atrium of his heart to allow for better blood flow. He was on ECMO for 5 days and removed on April 11th. He was on the ventilator for about 2 weeks. They noted that his liver wasn't doing well, but it was able to heal. This is actually, if you're able to zoom in a little, an photo of his EEG that was sent to me. You can note it's got good waveform. And that's what they kept saying to us is it looks like he's still in there and he's going to continue to fight. So we did note that some issues coming forward in the days would be his skin and kidneys. He developed blisters from his kidneys being shut down, and they described it to us as his body needed to get rid of the waste and was pushing it to his limbs. You can note some blisters growing on the legs. And they did start him on CRRT to remove a lot of the waste, and would later actually put him on a more firm dialysis for a little while. I know in EMS a lot of time we talk about, if somebody jabs himself with an EpiPen, they can get necrosis in their thumb. Aiden actually got necrosis from cardiac epi in his shoulder. I can go back a few slides. I don't know if this will show, but if you notice in his left shoulder here, this purpling, they noted that this was due to necrosis from the cardiac epi, and that it sat there and it killed the tissue. They told us that they gave him the antidote to fix that, but he did unfortunately get some skin damage from this. So then going back to here, he was placed on, so later put on temporary dialysis, and his kidneys took a month to come back online. So we were waiting for them to wake back up after everything. So this was part of the blisters on his leg, and you can notice the fluid that's kind of accumulating, and they would have to lance those to get all that fluid out. My brother actually had sent me a photo where there was a huge bag. It looked like a gallon bag of fluid that they had taken off because it was big. These are actually his legs today, so they are healing, but it's still, he's got some work to do to grow them back. I told him that he's going to have a good story to tell when he's older. These were actually taken, I think, last week. So he was moved to the heart and kidney unit. He left the ICU on April 29th. He was in the ICU for 3 weeks. He started PT for the use of his hands and learning to walk again. This is actually a photo of him moving to the next unit, and he did have a beautiful room there. This is the list of diagnoses that they labeled him to have. So COVID, junctional atopic tachycardia, cardiogenic shock, hypovolemic shock, metabolic acidosis, and you can kind of see the rest of them. There's not too many shocks that are not on there that he didn't get labeled with. On May 24th, he was discharged home, and that is a photo of him saying goodbye to Children's National. To this date, his skin continues to heal. It is very sensitive. He does often have to keep it covered up. He continues to strengthen his walking skills. His kidneys are doing well, but still does have some work to do. He was labeled with stage 3 kidney disease, and he will be on blood pressure meds for life. He had a procedure to close the hole in his heart on September 12th with success. And then on August 23rd, Aiden got to start kindergarten this year. And that is actually a photo of his first day in kindergarten. So this is photos of him and all the teams that helped him. The one with, I guess it's my right, was the lady that actually did CPR on him and recognized him going into cardiac arrest. The one in the center was the team at St. Mary's that helped him out. And then in the top left corner is my brother with his team of doctors at Children's National. So it was good that he got to go back and visit them and see he was doing well. Any questions on that case? Kate, do you want me to go into the review of the septic shock stuff?
Yeah, go right ahead. You're doing great.
Okay. So as you can see, we definitely went through septic shock with Aiden. So what is sepsis? It's an extreme reaction to the body. It's an exaggeration of our body's normal immune system. They call it SIRS, or systemic inflammatory response syndrome. It can cause vasodilation, which causes your container to get bigger and your BP gets lower. The one thing that I noted, and if I noted it with the St. Mary's crew, is they noted shallow breathing but clear lungs. And it's because the fluid they were giving to him, they were worried about it turning into pulmonary edema. And it did note that fever can be absent in patients. And with him, he never had a high fever, just a very low one. So what are the symptoms we look for? High heart rate, weak pulse, fever, shivering, confusion. We often talk about a new onset of altered mental status, shortness of breath, clammy skin. Is from the CDC. So if we look at our pediatric criteria for sepsis, the identification. So if we go through this, the only one that Aiden doesn't really check off is that temperature one. But he had a heart rate greater than a normal range. He had an altered mental status. Capillary refill time was severely extended, mottled cold extremities. And I think if the crew had done an end tidal in the truck, definitely would have been lower than 25. And for his age range, his heart rate was above 140. So he met, if he was here in Vermont, he would have met sepsis criteria for us. So we look at the protocol. A lot of it is management and managing those symptoms. Obviously, if their oxygenation's low, we want to try to achieve it to be 94 to 98. We check a blood sugar to check the altered mental status, and we administer fluids as appropriately, and continuing to recheck those lung sounds, and then get them to the closest appropriate facility. Any questions for me? And that is our story of septic shock last April.
Jenna, Peter Simkowitz had a question. Did they identify the cause of the infection?
So their leading theory was myocarditis due to an asymptomatic case of COVID. But they said that because of all the replacements in the fluids that they did and the blood products, that we probably would truly never know what it was from. But that was their leading theory.
I think your brother said Aiden's with him. If you want to stop sharing, maybe we can make your brother the speaker and see him, if that's okay.
Yeah, I'm okay with that. Let's see if I can do this.
All right. Where's Phil?
He is.
Oh, there he is. Can I make Phil the
Aiden, say hi.
You can pin, everyone can pin Phil and
yeah,
then.
if you pin Phil, you can see him, the 3 little dots.
Aiden, say hi, everyone.
Hi, everyone. Hi.
Hi, Aiden. Oh my gosh, Phil, that's so sweet. We appreciate you so much sharing your story.
Yep. He went through hell and back, and we're blessed that he's still here in the state he's in. Anything you want to say, Aiden? Nope.
Hey, Jenna, I got to say, from the very beginning, it sounds like the EMS did a great job recognizing and starting treatment. And I had a question. Do you know if they called ahead and said, we're coming in hot with a sick kid?
I don't, but I agree in that I was very impressed with what their interventions were. And as far as them getting a line in fluids right away. I was impressed after reading the issues they had with getting access on him, that they were able to get an IV in his hand even. That was incredible.
Hey, Jenna, Lisa said they did call ahead.
They did.
Say ow. Ow.
Sorry.
It's all good. It's all good. Jenna, you threw out a lot of terminology there. Just so everybody knows, Jenna and Phil and her family, the reason they're here tonight is to share and allow you to ask questions. If you have any questions about any of Aiden's care, or maybe what mom and dad were viewing the day of, they have been so gracious and kind with their time tonight to share this story, and we really appreciate it. So feel free to ask if you have any questions. Carl's got one. What causes the blood sugar to not respond to treatment? I don't actually know. Do you know, Dr. Dave?
I'm going to just go out on a limb and say multi-organ failure, and the sugar, the glucose metabolism not working correctly, or as part of it.
I'll buy that.
So one thing they noted to us is in the hospital is they felt that he was already starting to experience myocarditis on Wednesday, which was the vomiting and the unable to keep fluids down, so that they actually felt that this was something progressing over smaller. Yeah. it wasn't instantaneous, but they also said that his recovery was so quick because his progression to myocarditis was so fast, and that kids who have longer prolonged myocarditis are typically the harder ones to recover and typically have more long-term effects from it. And not just for reference, I was present with him during the cardiac arrest at Children's. Mom was present with him at the ER in the local hospital. So if there's any questions relative to those would be the folks. He likes to watch as I do it this way.
Bill, how did they support you? You know, when your son is so critically ill, would you be willing, because you know we're always talking about how we can support parents when we have pediatric calls. Can you share with us a little bit about that?
Are you talking about during the cardiac arrest or during the entire time in the hospital?
Anything you want to share that you think would be good for a good lesson for us or something for us to take away?
Yeah. He's gonna watch his iPad here, so I'm just gonna move quickly. So I can mom too. So okay, I'll just get saying. So as far as the night with the cardiac arrest, they gave us a doctor and a social worker for me. They were in a no-win situation with me. So as much as I know they were trying to protect me from passing out on the floor, I only wanted one thing. My only thing I knew to do was to get out of the room and get out of their way. I will say that what was incredibly impressive was how well rehearsed they were for cardiac arrests and how every single person exactly knew where to be, what their job was. They were pulling out all the medications and drawers, and every person was set up. As soon as they said they needed something, they got it in. They had to have had it. It looked like 30 people in his room. And Aiden's circumstance is a lot to do with, I think, the right time with the right people, because when he went into cardiac arrest, he already had 6 people over the top of him. So if he had been an hour later and they go, quote, sleeping, and then went into cardiac arrest with no one in his room, the outcome could have been very different because his stroke was very minor in perspective of how long he had been in and out of cardiac arrest. The biggest take we have is the CICU was constantly involving us. They were keeping us in the loop, but they were making us part of their rounds. And they, because of his autism, were constantly soliciting our feedback and recognizing the fact we were there 24/7 and took our inputs to as part of his care. And so that actually changed a lot, and it was definitely a collaborative effort. So listening to the parents, especially those with autism, with kids with autism, is huge because Aiden's reception to pain is very different than a normal child's.
That's amazing. Thank you so much for sharing all of that. Really powerful, and we're all so grateful that he looks so good and you look good. Yeah, that's amazing. Phil, there's some more questions on the chat. I don't know if you can see those. I don't want to do any triggering. There were some specific questions about CPR, but it sounds like it was a very well-practiced crew. And I think that's something we can all take away from this, is that, you know, these are not anything that we want to encounter, but the more we practice and our craft, the better we'll be in times of distress.
Yeah, he did have, it was all manual compressions because the doctor or nurse who was actually trying to diagnose the pulse ox machine, it was pretty noticed when his pulse ox started dropping, something was up. She quickly dropped everything and performed the CPR. We've actually been taking him to a chiropractor, and she could actually notate that his ribs being all displaced, that he was getting extensive CPR, and could tell what side they were kind of pressing on. So it was all CPR being performed. I can't say I watched a lot of it. I saw 2 of the 5 cardiac arrests that he went through. So, but actually triggering wise, doing pretty good now. So.
Yeah. Amazing. Thank you, Phil, for sharing your family story. We're absolutely in awe of everything and so grateful for this nice outcome. Jenna, strong work. You knocked it out of the park. That was fantastic. And we really appreciate your commitment to pediatric emergency preparedness. You did a great job, and we appreciate you. So thank you.
Thank you for letting me tell my story tonight. Hopefully it
Yes.
will help somebody down the road, so.
No, I think it's wonderful. I think it's wonderful. And, you know, we also, we know that not all of the pediatric calls that happen have good outcomes. And we know Aiden's got some therapy left to get to where he needs to be for optimal health. But, it was a really great presentation and, pretty impressive. Like, I know it's kind of over here, but yeah.
It was impressive to read through all the paperwork and all the different labs and the vital signs and the treatments. Like, as I kept going deeper and deeper, I was impressed with everything that had happened, and from the beginning of EMS being called to children's.
Dr. Dave?
Phil, I'm sorry, just quick question. With Aiden having autism, normally when he's feeling well and everything, I imagine people coming at him and touching him, he doesn't like very well. When the EMS first showed up, do you know, was he like that, or was he just kind of laying there and letting them do their things?
So he basically was just laying there. He was so out of it, we couldn't even get him to stand up. But his ability to kind of function was very little for the EMS folks. And I know they actually took several attempts to try to get the IV line in for sure. As he got more active, he was still lethargic through St. Mary's and into Children's, but we noticed that he would still react to like some pains and stuff. You would hear him say ow occasionally, but it was very faint, like you could tell he was sick. One thing we noted though with his autism was post kind of in the HKU, his pain meds actually had a very different reaction with him, and he actually, instead of making him feel better, it actually heightened his sensory issues. It actually made things worse. And then actually until we got him down to just Tylenol, his mental state was actually to come back much better. And he was actually much more receptive to doctors and care, because those higher dose medications and pain meds were actually causing him to really negatively react. So it was kind of an opposite of what everyone expected.
Thank you.
Yeah, thank you so much. All right, I think we're gonna move on. We've got about 20 minutes left and we have another case that we'd like to present. I'm gonna go ahead and share. Oh, can you allow me to share my screen, Chelsea? Sorry. I should have asked
No,
earlier.
it's fine. You're a co-host, so you should be able to. Let me hang on. Let me try to figure this out. Let's see. Okay, hang on. I think I got it now.
There we go.
Awesome.
Perfect. All right. So, can you see that?
Yes.
Okay, thank you very much. Hold on, let me hide these controls. Come on. Ooh. All right, so, this call is actually a Vermont case. Does it still look right, Dr. Dave?
Yes, looks great.
Okay, and this one is coming to us from Franklin County, from District 1, Enosburg Ambulance Service, and we're very lucky to have the primary provider from that call, Kelly Coda, who's a paramedic up in District 1. She also runs in a couple other places. Just fun fact, Kelly and I went to St. Mike's together, and she also gets hush money every month, but that's okay. Kelly, your service was dispatched to a 7-year-old female unresponsive 6-year-old. I think it says something in 2 different places.
Yes, so the child was 7. And it was interesting because we have 2 ambulances, but we staff 1. And so our second calls are whoever's available. This call came in at just after 4 o'clock in the afternoon, and I had just finished my day job. So I did a quick inventory of maybe who was available and who wasn't. And I immediately asked for mutual aid, thinking that other members weren't available, and I went to the scene.
So you even just like, PEP says pre-arrival preparation, right? So you started thinking about the resources you had available based on the traffic in the district, and you said, I need more help, unresponsive.
Yes, and that actually triggered two really good things. Our mutual aid partner up here is Richford Ambulance, and they came with 3 members because they heard it was a pediatric unresponsive, and they had a member in Enosburg who was wearing their pager and was basically across the street from the call, and he said, I need to go on this. And so I got on scene pretty quick, and he was the second one on scene. So we had an immediately pretty good hands. And then my regular longtime partner drives a school bus, and he had just finished up his bus run and called me and said, do you want me to bring the ambulance? And I said, yes. So we had a lot of resources coming to us right away.
Excellent. So you roll up on scene, and what was your window assessment as you got there?
So this call was for an unresponsive 7-year-old. Mom met me at the front door, extremely upset, and I asked what was wrong. And basically she saying one sentence, she's been sick for a few days. I don't know what's wrong with her. I just found her like this. I got home from work. My mother had been watching her. So the window assessment was, there was a lot of vomit. The student was mottled. They were, their lips were a shade of purple I had actually never seen in a child who was alive. And their hands and feet were basically cyanotic. Their nail beds were blue, and they were breathing agonally.
Yikes. So pediatric assessment triangle, super sick. So what was your first move?
So our first move was to extricate. We had one ambulance there, and the Richford crew was just a minute or so out, and I asked them to keep coming. And so we extricated from the house and into the ambulance and started working in the ambulance.
So was that was mostly the extent of the history that you were able to get?
The parent said otherwise healthy, had been sick, had been home from school most of the week, and had been sick. Wow. And that's pretty much all that mom could keep saying. You know, she's just been sick all week. I don't know what's wrong with her. My mother was watching her today. My mother just left, and I just came in to see her and found her like this.
Kelly, can I ask a logistics question?
Yes.
When and not I'm not criticizing, I just don't know. Would you ever stay there and start working? You know, IV, bag, any of that? I'm just what's the decision to say? Is it because everything's easier on the ambulance?
That was my train of thought. It was a very small space. It was very cluttered. There was not much lighting in there, and I like to work in what I call the office, my office, and I like to, a patient like that, all of my equipment is out in the ambulance.
And it takes 20, 30 seconds or less to a child that size to pick up and bring, is it right?
Right. So we were on the first floor, front bedroom. It was just a scoop, a few steps, and the ambulance was right there. So it was not a lengthy removal from the house.
Perfect. Thanks.
Can I also ask a question, Kelly, just for the perspective of all the participants? How far away from a hospital was this call?
That was 20 miles.
Wow. So maybe another reason to scoop and run.
Yeah.
So you got into your office, into the ambulance, and then how did you prioritize what you wanted to do?
So I tried to do an initial clearing of the airway, and the vomit that was on scene was just, I mean, I described it as meconium-like. I mean, it was very thick and very foul smelling, and just try to do a clearing of the airway. We then got in the ambulance, cleared the airway, tried to put an airway in her. She had a gag reflex. I couldn't intubate her. She had couldn't put a eye gel in her, so we put an oral airway in her. Looked at her extremities, and the AEMT who was on Richford ambulance, I work a lot with, and really good working relationship. We basically looked at each other and said, nope, we're not going to get an IV. And he put an IO in her very quickly. And so we were controlling our airway, getting access, getting vitals. So that was our initial treatment and priority.
And how did, and just keep going, you're doing great. How did, like, how did access go? What was her response? Would you give her that kind of stuff? So
we put an IO in her femur, and she had no response to that. So bad sign. And started some fluids, started bagging her. Her respiratory rate was like 6 and 8, and like I said, it was agonal at times. She was definitely kind of guppy breathing. Every once in a while she would take a deep breath, made sure her airway was clear, put her on some high flow oxygen, tried to do a neb with her too for some real funky sounding breath sounds. But that was like a little bit further down the road. But just trying to sort of figure out what was going on. And the only information we had was that the child had been sick for a few days. And her temperature, I don't think she was febrile for us. I think she actually was quite the opposite, if I remember right.
I think you're right. I think you indicated
it's like
pretty cool.
Yeah, 94 or something.
Yeah.
Remember right. Took her blood sugar, and that was normal. Our heart rate was 170. She surprisingly had a blood pressure, and it maintained above 100 the whole time. So we gave her some IV fluids and just started clicking off our checklist of what this could be. Partway through, I said, she must be septic. She's so shut down. She's so cold. One of the things that we did do was just turn up the heat in the ambulance to try and warm her up. And gave her IV fluids, called a septic alert, and headed to Northwestern.
Kelly, curious, again, a logistics question. Do you guys have heated fluids, or is it just regular fluids, regular temp?
At that time they were room temperature fluids. We have since gotten a warmer.
Not that it would have mattered probably, but still.
Right. Yep.
So you called ahead to Northwest and said, hey, this patient meets the sepsis alert, pediatric sepsis alert criteria that Jenna listed in her last presentation, and actually with a temperature of less than 36 centigrade, right? I mean, she was cold.
Yeah.
And
yes.
So was that your final destination, or did you transfer her after that, or did you deliver her to the ED?
We did not transfer her. I don't know actually who did, but I assumed HealthNet came and got her. Maybe you guys know that, but we did not.
Yeah.
Kelly was mom with you in the ambulance? Yes. And she was okay? She was letting you do your work? She was,
I mean, on scene, she was hysterical. I kind of think what happened in hearing things afterwards was grandma was watching the child was in the bedroom, and said she was going to take a nap, and grandma sort of looked in and said, okay, she's taking a nap. And when mom got home a few hours later, they did the pass off, and they said, okay, I'm leaving, I have something to do. She's taking a nap in the bedroom. And when mom came into the bedroom, mom saw that. So mom was pretty hysterical because she had been at work all day, and she had left the house, and actually she had gone home from school on Tuesday sick, was sick on Wednesday, was sick on Thursday, was feeling better Friday morning. This was a Friday. And mom said, well, I'll just keep her home one more day. And so when mom left for work, she was feeling better. So mom was quite hysterical because everything was wrong. Like I said, she was, her lips were like this deep crimson purple color. Her hands were blue, her feet were blue. And she just was a completely different child. So mom was quite hysterical.
Well, I think you guys did a fantastic job. I think this is a very, you know, when you show up on a scene like that and you don't have a great story, you have an unresponsive child. I thought your assessment of sepsis was perfect and fast and excellent. You know, I'm sure what was running through your minds, could this be an ingestion? Could this be, if it's, not, I know she was 7, a teenager ingestion, a younger patient, is this non-accidental trauma? I mean, just your mind is going crazy. But I reviewed Northwestern's information. They intubated the child, they initiated antibiotics, and they recognized sepsis. They also did a CAT scan. They did a full body scan because they didn't know what was going on either. And it appeared their assessment, and Kelly, I think they reached back, or you reached back and said that what they thought was going on is that her source of infection might have been appendicitis, and a perf appendicitis. And then I'll tell you, she got transported to UVM, to the ICU, and she was in the ICU, and her, like in Aiden's case, her pressures were bad, and she was tachycardic, and unfortunately she had sepsis caused complete organ dysfunction, and she ended up passing about 2 days later in the ICU at UVM. And I just want to say to everyone out there, we think of appendicitis as being fairly benign, and fortunately nowadays it is. But this child is not the first case that I have seen that in this age group that has had a perforated appendicitis, become septic, and died. And you telling me that she felt better on Friday, what pathophysiologically, probably what happened is she had appendicitis for a few days. She perforated maybe early Friday morning and felt better. So it's almost a little bit of a holiday. You feel better because the pressure's off. But then within hours is usually when you start becoming septic. So I think, unfortunately, when grandma, and she's feeling better, she was feeling better, she was looking better, I imagine, and then within those hours things changed rapidly. So but again, I think you guys did a great job.
Yeah. And looking back, I did see that we asked if she could have potentially gotten exposed to anything. So we were kind of thinking of that too. That was probably one of the few questions mom was able to answer. Did she injure herself? Did she get into anything? And that's when we were getting I don't know, I just got here, I don't think so. She was, mom said she was doing fine. So yeah, that was a lot of a really sick kid really fast.
And I think, I'm sorry.
No,
And that's one of the reasons, Kelly, I know that this was a really sad case that didn't have a happy outcome like Aiden. And we hope you and your crew are doing okay. But there was a couple things that we wanted this case to be shared with others. Was one, how quickly this happened, which we can see how the family was so reactive to having a child that was feeling better and then finding this child in such extremis, but also that in the midst of the chaos that you picked up on, she's been sick for days. And I feel like that's really the only clue you had that this has got to be it. And then put together all of her symptoms of circulatory collapse and her cold and her mental status and her modeled. And I know I took the slide down, but I just wanted to give a shout out to Enosburg. That handoff form is really nice, how you have the STEMI alert, stroke alert, sepsis alert handoff for the emergency department. And I thought that I just wanted to show everybody that that's a tool that you use to strengthen the chain of communication between pre-hospital and the emergency department staff. So strong work on that.
Kelly, there's a question. Did you happen to know what the MAP was, the mean arterial pressure or blood pressures, or were they just low?
I actually. I can figure that out in 2 seconds. Hold on.
And I can just say, I mean, obviously both of these children were super sick on EMS arrival, and that's why it's important for all of you out there, you know, to try and pick up on, we want to pick up on these children and anybody in the early stages of sepsis, which in a child could be just tachycardia. And that can be really tough because you know, kids got tachycardic from fever, from dehydration, from fear, from so many different things. So, but again, tachycardia is an early sign of sepsis, especially if there's not a good reason to be tachycardic.
Which is all the more reason that we should, and I'm, you know what, I'm just gonna, I know we're running out of time here, but I did just wanna, am I sharing again? Okay, thank you. Just another shout out for our magnificent Vermont EMS app. I know it can be sometimes wordy, but if you go to protocols and you go down to appendices and the pediatric color-coded appendix, if you're not sure what the normal heart rate range is for a child whose age you know, you can scroll down and up in that upper left-hand corner, it will list, you know, the normal heart rate ranges. But I think it's meaningful to say, hey, this child's tachycardic, what's going on? And it's an abnormal finding and report it, because although it might not tip me off, maybe to the receiving provider, they're like, ooh, this isn't good. I'm going to do a fever workup, or I'm going to check some other things because sepsis is at the top of my list. So that's awesome. Does anybody have any other questions for Kelly? A great presentation, Kelly. I appreciate it. I know that was a hard call, but it was an important one because it really put into focus how you took such limited data and came up with something to notify the hospital of.
Great teamwork.
Yeah. And the
Yep.
teamwork, I mean, I can't express enough the thankfulness that Richford was working with us that day. And you know, we usually kind of scramble for a second call, and when it becomes then that serious, when everybody's sort of out of the woodwork, the Richford member who, you know, took it upon himself, he was shopping in Enosburg and dropped everything to come and help us, and he was first on scene with me, and then my partner who finished his bus run came and got the ambulance, and then Richford having the forethought to have multiple members more than their regular staff because they heard it was a sick kid.
Yeah, and I think it's probably not unique to just the Enosburg, Richford area to have multiple rural agencies working together to get the resources they need. So, and to that end, please answer Bambi's survey so that we can get the legislature to hear what we need. So that was two very different calls, but very amazing. Thank you both so much for presenting. Jenna, strong work. You did a great job on your PowerPoint. Kelly, thanks for being here. Tell everybody up north we said thank you.
Kelsey, do we have another question, a Zoom question before everyone leaves?
Zoom question. Yep.
Yeah. Okay.
Yeah. Cut
I
in
just
whenever you
launched it.
want.
Whoever's here. So same question as before. It's all anonymous. Thank you everyone for filling this out.
And then do we have a certificate, or should they just, you know, should we get that to them at a later date?
People can email me. I don't have one to put in the chat, but I can put in the chat an email address. that people can see at vermont.gov. Whoops, vermont.gov, and I can email it to you.
Courtney, or I'm sorry, not Courtney. Courtney can put this on Vector for you since it's recorded.
Yep.
And you can issue the certificates right from there for anybody that's here.
Perfect.
I just want to throw that out there.
Thank you. Okay, ending the poll.
There you go.
Great. Thank you, everyone.
Yes, thank you. Remember, next month we're doing respiratory, right?
Yes, next month is respiratory.
And that's on October 20 something, blah, 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 25, Wednesday, 25th.
Nice.
And for anyone just staying on, Chelsea and I are the Always Ready for Children. We're reaching out to all our local EDs and helping facilitate that, the filling out and the assessment. And so we will be in your neighborhood in the next couple months, hopefully.
Dr. Nelson, have you followed up with VAS at all? Because they can help with that.
They are, yes, so I got invited to the medical directors meeting, and VAS, they were there, and yep. So thanks.
I was talking to Devin about that. I was meeting with them yesterday. And I was talking to Devin about that, and she's like, "Oh, we can help. Let us know if we can do anything to facilitate that."
Thanks, Kelly. Were you saying goodbye, or did you say you had a question?
No, I'm saying goodbye.
Oh.
Oh,
Thank you,
bye,
Kelly.
thanks.
Thanks, Kelly. Bambi, Devin was, I believe she was there at the meeting, and they've invited me now monthly to come to their meeting, so I'll give them an update. We already, from when Chelsea and I sent this information out just a couple weeks ago, we've already had four or five hospitals contact us, and we're trying to arrange dates. I think the only date we have so far for sure is with Rutland, but
That is fantastic, because I know it's
great
hard
response.
to connect with them. Yeah, that's really exciting.
Kate, you're in the office.
Is Kate still on?
Kate, no one handing you a drink at the end of the
Oh, I
show?
know. Stop recording, Chelsea.
Oh,
By drink, I mean Pepsi or ginger